The topic for discussion today is ulcers. To deal with ulcer is actually derived from a Latin word called as ulcus. Ulcus is nothing but sore. To define, Somendas has defined ulcer as actually a break in the continuity of the covering epithelium, may it be skin or mucous membrane. It may either follow a molecular death of the cell surface or a traumatic removal. This is called as ulcer. It is nothing but in simple terms, it is breach in the epithelium. Burkitt has defined ulcer as a well-defined, well-circumscribed lesion where it's often depressed lesion with an epithelial defect that is actually covered with the fibrin clot causing yellow-white appearance. But however, there is small deviation from this definition because not all ulcers need to be well-defined ulcers. There can be ulcers which are irregularly with irregular margins and different types of margins again. So now coming to difference between ulcer and erosion. Ulcer is actually a deeper one. It is a deeper crater that extends through the entire thickness of the epithelium and sometimes involves the underlying connective tissue. Whereas an erosion is actually a shallower form. It is a shallow type of a crater that extends through the entire or partial thickness of the surface epithelium. Now coming to the parts of ulcers. Ulcer actually has four main parts. One is the margin, base, floor and edge of the ulcer. Margin is nothing but the periphery of the ulcer. Based upon the type of margin and its features, we can actually classify ulcers again into healing ulcers and non-healing ulcers. In case of healing ulcers, the margins are usually sloping down and they have a nice pink color in shape. Whereas in case of non-healing ulcers, the ulcers are usually extensive and it is highly inflamed and edematous in nature. So this is how we actually identify a healing ulcer and a non-healing ulcer based upon the margin. Now coming to edge of an ulcer, in this picture we can actually see the periphery of the lesion is margin, whereas the undercut of the whole ulcer is the edge of an ulcer. Floor of the ulcer is nothing but what we actually see. That is nothing but the actual lower part of your ulcer, the floor of an ulcer. Base of an ulcer is more of a palpatory finding than an inspectory finding. Base has to be palpated than appreciated by vision. Normally we catch off the base within the two fingers, in between the two fingers, and we can actually move it. So this is called as base of an ulcer. Sometimes what happens in case of very deep ulcers like a trophic ulcer or pressure ulcer or decubitus ulcers, in those what happens is the base of an ulcer can be as deep as the underlying bone or muscle or tendon. So in those cases what happens, that underneath bone actually becomes a base of an ulcer. So these are actually the various parts of an ulcers. Now coming to examination of ulcer. History always gives us a good insight into what kind of ulcer it is. First thing is mode of onset. In case of mode of onset, usually some ulcers are either spontaneous ulcers or they actually follow some trauma. Trauma ulcers are nothing but traumatic ulcers, and then spontaneous ulcers can also be seen where there is no actual traumatic cause, where these spontaneous ulcers can be in case of erythema multiforme, or these ulcers can be like some kind of herpetic lesions, etc. can be again a spontaneous lesions. Some ulcers will have vesicular formation where a vesicle is formed, it actually bursts and gives rise to an ulcer or an erosion. Most commonly seen in case of herpetic lesions. Herpetic lesions usually, most of the viral lesions like cytomegalovirus lesions, etc., or hand, foot, mouth lesions, etc., they actually actually come out like a vesicle, and these vesicles are nothing but fluid-filled blisters, right? These fluid-filled blisters break to give rise to ulcers. Sometimes, like in herpetic lesions, like in herpes zoster lesions, what happens? These small vesicles which burst into ulcers coalesce again to form a irregularly or ill-defined margin ulcer, so which can be a big ulcer then. Sometimes there can be vesicles with fever. Most commonly like prodromal symptoms of fever can be seen in case of viral infections. Some ulcers can occur based on intake of drugs such as NSAIDs. Some NSAIDs can cause ulcerations and some sulfonamide drugs can cause ulcerations, which usually manifest like erythema multiforme. And then we have allergic conditions. Allergic conditions can be again stomatitis medicamentosa is an example, stomatitis veninata is an example, and certain allergies based upon drugs or just pollen grains or latex allergy itself can cause ulcerations. That is wounds which actually form into erosions or ulcers. So when duration also help us. This duration is actually divided into an acute ulcer or chronic ulcer. Acute ulcer usually occurs within few days to weeks, and then in chronic ulcer it can extend from weeks to months. and there is something called as incubation period. Incubation period is nothing but from the time of inoculation till the ulcer appears, till the symptom appears, it is called as incubation period again. And this picture, in the first picture, we can see after stomatitis, where a well-defined ulcer seen, where with a greyish slough on the floor of the ulcer, surrounded by a well-defined erythematous halo, which is the characteristic feature of again after stomatitis. And here we can see another ulcer on the tongue there. And then coming to pain of pain. Some ulcers are usually painful and some are usually painless. Usually inflammatory lesions are painful in condition, whereas in case of any ulceroproliferative lesions like carcinomas and squamous cell carcinoma, sometimes basal cell carcinoma, are usually painless initially, but when due to secondary infection or invasion of the adjacent structures, it can become painful eventually. Coming to discharge, certain ulcers have different types of discharges. Watery discharge can be seen, serous discharge can be seen, and in some cases we can also see purulent discharge. Usually ulcers which are caused because of any bacterial conditions can lead to purulent discharge again. Now coming to any associated diseases. Some diseases usually have manifestations in the form of ulcers, for example syphilis. In case of syphilis, we can see clear-cut punched out lesions can be seen, mucus patches can be seen, and there can be gummas which can be seen usually on the tongue and palate. So associated diseases, associated with various diseases, we can also see ulcers in few cases. Now coming to local or physical examination of an ulcer. When we are seeing an ulcer or inspecting an ulcer, these features have to be kept in mind. One is size and shape. Coming to size of an ulcer, usually some ulcers are very small in size, less than 1 mm or less than 1 cm, and some ulcers are greater than 1 cm in size. For example, aphthous ulcers. When we are talking, because as an oral physician or dentist, we will talk about oral cavity lesions. Small ulcers are usually based again in size and shape. We can differentiate. In case of deep fungal infections, number of ulcers also will be less. Multiple ulcers can be seen or solitary ulcers can be seen. Solitary ulcers usually seen in case of deep fungal infections like actinomycosis, blastomycosis, histoplasmosis, and in case of any malignancies also we can see usually solitary ulcers. And multiple ulcers can be seen in case of erythema multiforme, in case of herpetic lesions, in case of zoster, etc. We can see multiple ulcers also. And based upon the position, in case of pressure points, sometimes at the region of pressure, we can see trophic ulcers, or we can see bed sores, we can see. So based upon the site of the lesion also, we can see we can actually come to a diagnosis of which diagnosis it is. For example, in case of an ankle, an ulcer at the ankle region, it can be a venous ulcer sometimes. So based upon this position also, we can actually talk about different types of lesions. Traumatic ulcers usually seen at the shin area or skin, which is very much in proximity to the bony prominences. In those cases, traumatic ulcers are usually more commonly seen. So based position of an ulcer also gives us an insight into which type of ulcer it is. Now when we are talking about an edge of an ulcer, as we have discussed, gives us an insight whether it is a healing ulcer or non-healing ulcer. And edges also, we have various types of edges. We have punched out edges, we have sloping edges, we have everted edges, rolled out edges, we have white pearly edges can be seen, and we have floor. And the floor of an ulcer also gives us an insight. If the floor is very black in color, then we can think about malignant melanoma. If the floor is very deep, where it is sometimes bone can be seen, then we can actually think about any pressure ulcer again there. Based upon discharge also, whether it is secondarily infected or not, we can identify. And in case of any infection or effect on the surrounding skin also, will let us know about the type of lesion it is. Then when we are talking about size and shape, we will talk about tuberculous ulcers. Usually cold sores will be present, which can again form into with a special undermining edges will be seen in case of tuberculous ulcers. In this undermining edges, what happens is the infection spreads subcutaneously into like a burrowing type, leaving a thin friable superficial layer, skin over there, skin or even the mucosa. So tuberculous ulcers has a characteristic undermining edges can be seen. In case of syphilitic ulcers, usually 1 or 2 solitary ulcers usually these are, and in syphilitic ulcer we can nicely see a punched out margin, as if we have punched the area, as if we have punched that particular tissue. Ulcer is usually well defined punched out type of lesion, and usually in case of syphilitic ulcers, the infection is confined within that punched. Usually very rare conditions it spreads into adjacent structures. In case of varicose ulcers, Varicose ulcers are again of multiple number, and they have a tortuous, it is present along the tortuous varicose veins. So varicose ulcers can be seen. In case of carcinomatous ulcers, usually solitary in nature, and these also have a well defined, or they have averted edges and ill defined peripheries can be seen. Indurated base, indurated margin and indurated edges can be seen in this case of lesions. In recurrent aphthous stomatitis, multiple ulcers, sometimes solitary, can be seen. They have well defined, usually surrounded by an erythematous halo, and by a pseudomembranous slough can be seen, or a greyish slough can be seen on these lesions. In case of herpetiform lesions, in this, these ulcers are actually a type of aphthous ulcers, but they actually resemble herpes. Hence, it is called as herpetiform, that is herpes-like. There can be multiple in number. Small vesicles can be seen in case of this herpetiform ulcers. Based upon the number of ulcers, we have solitary ulcers and again multiple ulcers. Solitary ulcers, as we have again discussed about solitary and multiple ulcers, right? Then coming to position, varicose ulcers can be seen. Rodent ulcers. Rodent ulcers are nothing but basal cell carcinoma, usually most commonly seen in the middle 1/3 of the face, which are usually exposed to more amount of sunlight, like more amount of UV radiation. Tuberculous ulcers, most commonly in at the nodal sites, wherever the nodes are there, we can actually see this tuberculous ulcers. In the case of extranodal sites, tongue is a dorsal surface of a tongue is most common site again for tuberculous ulcers in the oral cavity. Now, when we're talking about the edge, so spreading ulcer edge in case of non-inflamed, and healing ulcer edge can be seen in case of a nice well-defined sloping edges can be seen in case of a healing ulcer edges. And we have something called as undermined edges. As we discussed, it is nothing but your tuberculosis, where the subcutaneous tissue is being burrowed, it is being infected and necrotized, and the superficial layer is still present there. Now coming to punched out lesion in case of gummatous ulcer like syphilis, the edge drops at right angle nicely to the skin surface. And sloping ulcer edges in case of healing ulcers such as traumatic ulcers. Raised and pearly white beaded edge in case of rodent ulcer, and rolled out or reverted edges in case of squamous cell carcinoma. So when we are talking about floor is nothing but what we actually see. It is nothing but the lowest part, the floor of the ulcer, and we normally in case of good healing tissue, we can see granulation tissue, and we also can see two edges. That nice pink color of granulation tissue is actually tells us that is healing soon. If it is complete red in color or complete white in color, then it is like slow healing or non-healing ulcers. And coming to the surrounding skin, this ulcer where we can see erythematous border surrounding like an aphthous stomatitis, and tenderness. Usually in case of all inflammatory swellings, we can elicit tenderness, and in case of malignant swellings, usually they are painless, but they become painful when they are secondarily infected or when they actually invade the adjacent nerve tissues. Next, induration. Induration is again a pathognomic feature of squamous cell carcinomas, where the adjacent base and margin is hard in consistency, it is fibrotic. However, in chronic long-standing traumatic ulcers also we can see indurated margins. And base of an ulcer, as we discussed, it is about how we actually hold it between the fingers and move the edge, move the base of the lesion. And then depth also can be measured with the help of a measuring tape. We can actually measure the depth based upon the depth. Usually in case of venous ulcers or in case of pressure ulcers or decubitus ulcers, depth of an ulcer is very much deep, and bleeding can be seen in case of venous ulcers again, and relationship with underlying structures like in decubitus ulcers, and surrounding skin also can be associated in case of this ulcers. Now coming to focal examination, whenever we are checking for lymph nodes, as we have discussed, ulcers can occur in case of some specific infections also, for example tuberculosis. So examination of lymph nodes usually gives us an insight into what if there is any underlying cause for the disease. For example, when we are talking about a normal inflammatory ulcer, then the local lymph nodes can be tender, or local lymph nodes will be usually tender on palpation, and they'll actually have all the inflammatory signs around that. If it is a carcinomatous lesion, carcinomatous ulcer, then the lymph nodes there are usually stony hard, firm, or usually stony hard, fixed to underlying structures, not mobile, and usually the shape is roughly usually becomes circular in shape because of infiltration of the carcinomatous cells within these lymph nodes. When we are talking again about tuberculous ulcers, in those tuberculous ulcers, what we can see, lymph nodes are usually matted, we can actually palpate a matted kind of lymph nodes in case of if it is a tuberculous ulcer. So this is how examination of lymph nodes happen. Now coming to examination of vascular insufficiency. In this vascular insufficiency, what happens? It can be either a claudication of the vascular claudication of the blood vessel there. What happens? There will be a decreased perfusion of blood to those regions. Usually seen in case of your ankle, in the ankle region, on the medial side of the ankle, usually it is seen. Basins ulcer is one that kind of ulcer where usually seen in case of young women who are a little chubby or little fat, where they have more amount of fat tissue at the ankle region. This can be because of your decreased blood supply or vascular insufficiency. Now coming to examination of nerve lesions. For example, in case of trigeminal neuralgia or most commonly post-herpetic neuralgia. In this post-herpetic neuralgia, what happens is normally there will be herpes infections, and in this herpes, a herpes zoster infection is present. After the healing of zoster infection, even after 180 days, that is up to 3 months, if the pain is not coming down or if there is a persistent pain in the region, then it is called as post-herpetic neuralgia. So examination of nerve lesions associated with these ulcers is also very important. Next, we have certain diagnostic features of Colliman where we have to check for size, we have to check for shape of the ulcer, also check for the location of the ulcer, also check for the various features like the edge of an ulcer, margin of an ulcer, base of an ulcer, and also your floor of an ulcer. So based upon these findings, you come to a diagnostic provisional diagnosis. These are the Colliman diagnostic features of ulcers. In this picture, we can see regurgitated disease. Regurgitated disease is nothing but in case of natal teeth. When the child has a natal teeth, there will be problem with sucking, and also there will be trauma to the lower lip because of this impending teeth there, sharp cusp teeth are there. Next, coming to classification of these ulcerative lesions. Usually they are clinically classified as spreading ulcer or healing ulcer. Spreading ulcer is also nothing but phase-genic ulcer. And we can also say callus ulcer or chronic ulcer. This callus or chronic ulcer usually they doesn't have any tendency towards healing. These are usually long-standing chronic ulcers. They actually have a particular feature called as washed leathery slough, especially in case of gummatous ulcer. Now coming to pathological classification, usually they are divided into non-specific and specific lesion. Non-specific, usually traumatic ulcers. They are traumatic ulcer because of any trauma or any sharp cusp within the oral cavity, and then any accidental injury like brush injury, etc. In case of arterial ulcers usually in the region of any ulcer in the region of your arterial supply, and similarly in the venous ulcers also. We have something called neurogenic or trophic ulcers. Ulcers associated with other diseases like syphilitic lesions, tuberculosis, and tropical ulcers usually seen in case of in tropical region actually seen. And then infective ulcers, because like Duckray's ulcers, Duckray's ulcers is nothing but Haemophilus ulcers, where Haemophilus duckrae is actually causing this kind of ulcers, also called as infective ulcers. Infectious ulcers are also present, nothing but your syphilitic, only just by inoculation. Even herpes also, by inoculation or touch, it can actually spread from one person to another person. So these are various types of ulcers based upon their non-specific types of ulcers. Now coming to specific ulcers again we have specific ulcers like Marjolin's ulcer, where secondary ulcer associated with burns, and we have something called as Magdalene's ulcer, where it is nothing but your hypertensive ulcer, okay. And then lastly we have malignant ulcers. Usually ulceroproliferative growths are seen in case of this malignant ulcers. And this is a traumatic ulcer, nothing but regurgitated disease. And this picture shows where arterial ulcer, and this is a picture which is usually showing venous ulcer. Now coming to neurogenic ulcer, usually seen in case of peripheral neuropathy or in case of any pressure ulcers. This kind of ulcers can be seen. Mactorell's ulcer is nothing but in case of atherosclerosis or hypertensive patients. Mactorell's ulcer is most commonly seen. Malini's ulcer also called as Duckray's ulcer. In this, it is because of Haemophilus duckrae, most commonly seen in post-operative wounds. And there's formation of soft chancre or cancroid, especially in the nodal region, also called as Bubo's abscess. Okay, this is seen in case of Malini's ulcer. So these are various types of ulcers that we actually come across. Now coming to your management. Whenever we are managing ulcers, identify the exact etiology. By identifying the exact etiology and treating the etiology, your ulcer can most of the time subside. Proper history, physical examination and local systemic assessment is also very useful. Identify and correct any morbid factors associated with it. Nicely dress the ulcer, properly dressing of ulcer with antiseptic solutions and normal saline solution. Debridement of any pseudomembranous slough present there will also help in faster healing. In those ulcers, if there is pus, make sure that there is adequate pus drainage. Drainage and de-sloughing of ulcer promotes better healing. Ideal dressing should always be soft, absorbent type, non-allergic and non-adherent. And hydrocelluloid gel, compound forms of gel are very useful in case of this, in case of treatment of these ulcers. Next, we have something called as microporous polyurethane films, also called as Leoform, for shallow ulcers and for especially in case of burns and any skin graft donors. And it is actually this microporous polyurethane films should not be used for cases of like excessive exudate formation. Okay, this is how you actually manage the ulcers. And sometimes ulcers are usually associated with certain prodromal symptoms like fever and pain. So in those cases, it is always advisable to give any antipyretics and analgesics. Some ulcers are can heal better with steroids, especially corticosteroids like triamcinolone and dexamethasone, and because it actually decreases the inflammatory reaction there. So, and in cases where usage of steroids is required, has to be given, but make sure that there is proper tapering of the dosage of the steroids has to be taken care of. So this is all about ulcers and how various types of ulcers are present, how we actually diagnose these ulcers, how we examine those ulcers, and what is the management protocol for these ulcers. Thank you.